Hello, my name is Michael John, and it's my pleasure to give you this presentation on refugee and asylum seeker populations. I'll start off with a brief introduction of myself and an introductory case about this topic. We will talk about the definitions for refugee and asylum seeker populations, as well as the specific epidemiology or health needs and trends of these populations. We'll talk about specific factors that influence access to healthcare and can be a challenge to healthcare. And we'll be talking about potential resources to use to care for people who are refugees and asylum seekers. So first, a little bit about myself. I did my emergency medicine training at Baylor College of Medicine here in Houston, Texas, and I completed a diploma in tropical medicine during residency. After graduating residency, I stayed on as an assistant professor, finishing a 2-year fellowship in global health and international emergency medicine, where I worked on projects in Belize and Liberia. I also completed a master's in global health policy by distance learning from the University of London School of Hygiene and Tropical Medicine. Between the years of 2019 and 2022, I worked part-time with Baylor, and I spent about 60% of my time working abroad with the organization Doctors Without Borders, or MSF by the international name. These included 2 assignments at a pediatric hospital in Sierra Leone, and 6 COVID assignments across the world, including Brazil, Lebanon, Peru, the occupied Palestinian territories, and Malawi. In the meantime, I've continued some academic global EM projects focusing on sepsis and trauma care in Belize and EM training in Liberia. I've been involved in a few global groups looking at systematic reviews looking at emergency and critical care. And I am involved in local Houston programs looking at social determinants of health. Now, the presentation we're going to be talking about will be talking about issues that are inherently political. This is the classification of people crossing international borders and the resources available to them. Now, I'll be sharing a lot of perspectives from different organizations and institutions, but I do want to stress that in this presentation, all the opinions that I express will be my own and don't necessarily reflect Baylor College of Medicine or MSF. And also, any photos that do not have a photo credit are taken by me and with permission of the participants. So with that, I would like you to take a step out and travel back in time 10 years ago. I want to talk a little bit about my first exposure to a refugee setting. So the year was 2012, and I was in southeastern Liberia. The previous year, civil war had broken out in the neighboring country, Cote d'Ivoire. The fighting escalated in the spring of the previous year, and there was a ceasefire negotiated in April. Throughout the civil war, rebel forces moved from the north of the country, Cote d'Ivoire, to the south, and this displaced approximately 100,000 people into Liberia. Now, in this region of West Africa, there has been many civil wars and regional wars in the last few decades, and specifically Liberian civil wars between 1990 and 2003. There was actually a lot of movement across this border between Liberia and Sierra Leone, and there were a lot of shared ethnic groups and communities. This is a snapshot from the Office of Coordination of Humanitarian Affairs from the UN of April in 2012. And it shows the displaced peoples who are in Liberia as well as the movements of people. So at this time, there were still approximately 60,000 people in Liberia. This is 1 year after the fighting stopped. The majority of these people or refugees from Cote d'Ivoire were residing in camps along the border counties, but there were also many people living in the community. You can also see by the arrows that people were still moving. So in this month, by this time, 4,000 refugees had voluntarily repatriated to Cote d'Ivoire, but also during this time, 3,400 Liberians were repatriated from neighboring countries. Now, these are Liberians that fled over 10 years ago during their civil war, and you can see how the process continues over a prolonged period of time. Now, to put this into perspective, so 100,000 people were displaced from Cote d'Ivoire to Liberia. In 2011 and 2012, there were a total of 40 people admitted from Cote d'Ivoire into the USA. Whereas in this time period, over 300 people were admitted from Liberia. People that had fled from Liberia during the Civil War, displaced into neighboring countries like Cote d'Ivoire, Sierra Leone, Ghana, and had been resettled into the USA, again, almost 10 years after the war ended. So I'd just like to put you into perspective of how these situations can evolve and the time frame we're talking about and the scale of people and the number and the percentage that are ultimately resettled in third countries. So let's talk a little bit about the definitions and the recent worldwide trends around these populations of concern. So there are specific legal international definitions for refugees, asylum seekers, and asylum seekers. Internationally displaced persons are a less defined legal term. For refugees, their specific definition comes out of the 1951 Geneva Convention relating to the status of refugees. These are people fleeing for specific reasons who are unable to safely return to their own country and have been granted this status or recognized under the convention. Asylum seekers are individuals who have sought refugee status and who are still in process or have not yet been granted refugee status. And then whereas IDPs are a larger group of people who have not necessarily crossed an international border, but still may be fleeing for the exact same reasons that asylum seekers and refugees may be fleeing. What does this look like worldwide? And this is from the UNHCR, or UN High Commission for Refugees Global Trends Report, the most recent being 2021. This is showing at the end of 2020 the millions of people that are displaced around the world. And specifically, they highlight Venezuelans as well, who have been displaced in the red. And in the blue is all other refugees. And you can see that actually the number one country for refugees refugees in the country is Turkey. And that is predominantly from refugees from Syria, also from other neighboring conflicts or protracted disasters. And you can see that in relation to the global north or high-income countries, that actually the vast majority of refugees around the world are residing in low and middle-income countries or the global south. Those top countries highlighted here: Turkey, Pakistan, Sudan, Uganda, Colombia. Now, for internally displaced peoples, the scale is much different. The same kind of size bubbles in the previous are actually doubled. So where there were 4 million in Turkey, there are 8 million still displaced in Syria. And others displaced in Yemen, Somalia, Democratic Republic of Congo, and in Colombia. Again, pay attention to the scale for the number of asylum seekers. Here, the USA is number one in the total number of asylum seekers or pending cases at the end of 2020. And this represents about 1 million cases that are open in the United States. And you can see where other open cases are around the world. To put this into perspective for this year, in the year of this figure, there were 250,000 new asylum seekers. This is from a subsequent report that had included 2021. And you can see that the numbers of populations have continued to grow over the last 6 years. In blue are the refugees. In turquoise are people who are internally displaced. And then additional populations that are specifically tracked by UNHCR, as well as the asylum seekers there in dark blue. Now, of course, as many of you know, in 2022, we saw an unprecedented displacement of peoples during this decade from the conflict and war in Ukraine. So this is a snapshot from UNHCR's database data portal from last week or 2 weeks ago, tracking approximately 8 million total people have fled Ukraine across Europe, including 5 million who have sought specific temporary protection or refugee status. This is approximately equal to the total number of Syrians that have fled the country over the 10-year conflict. And you can remember from the previous slide, this represents almost 10% of all people the previous year, 94 million people around the world that had been displaced. So this gives you an idea of the scale of the recent conflict, and also gives you a sense of, at the same time, the amount of attention that's been given to this specific population compared to ongoing conflicts and ongoing displacement around the world. So now we'll shift our focus specifically to the needs and resources for refugees and asylum seekers here in the USA. In this figure from the Migration Policy Institute, you can look at the trends for the ceiling of refugees and the number of refugees admitted to the USA since 1980. Although the ceiling has been raised since the last presidential administration, the number of refugees admitted to the USA has lagged. One of the reasons for this lag is the protracted process it takes to be admitted to the USA as a refugee. The first step is to flee across a recognized international border and obtain refugee status. So in the example of the introductory case, a refugee from Cote d'Ivoire must flee across the Ivorian-Liberian border and obtain refugee status while in Liberia. The next step is referral to the U.S. admission program by either UNHCR or a U.S. embassy and to complete the application. Then their refugees undergo a prolonged and multi-step screening, vetting, and clearance process that includes a health screening and multiple security tests. Finally, after approval, the refugee will go into the placement process by a resettlement agency. And finally, there will be preparation and arrival. When we examine the health needs and epidemiology of refugees, the first principle that applies is that the burden of disease and epidemiology of the people who are refugees are going to most closely reflect the community from where they came. Whether that's maternal or child health issues or non-communicable diseases like hypertension or diabetes, the predominant needs of the refugees are going to be the same health needs that they would have had in their home community. Of course, during the refugee process, fleeing the country, exposure to disaster leads to many possible acute illnesses from infectious disease, trauma, and psychological or mental health illness. During the screening and resettlement process, refugees could be screened specifically for tuberculosis and other infectious diseases, and treatment or initiation of care may be a requirement for them to be accepted into the USA. During this process often includes adult and child immunizations. After resettlement in the USA, refugees may seek care for chronic illnesses that include latent infections or prolonged psychiatric or mental health illnesses from the resettlement experience. When we talk about health needs and health care for refugees, one specific distinction applies, and that is that refugees have health insurance. Initially, they're covered by the Refugee Medical Assistance Program that lasts for the initial 8 months they're in the USA, and then they are automatically enrolled in Medicaid, but usually will have to reapply. This is an exception with all other immigrants populations that may not have access to government-assisted health insurance. With refugees and any immigrant population or population with low English proficiency, the language and help in navigation is essential. There's many studies and papers talking about the use of qualified and trained interpreters and how the lack of trained interpreters can really harm the communication and care that refugees and their families receive. Key practices in preparation, such as having interpretation services available, correct physical arrangement of interpreter videos or iPads or in-person interpreters, as well as clear communication styles can help overcome some of these challenges. And they're summarized in this review article cited here. In addition to health resources, often refugees are embraced by a network of state and local agencies and organizations. Here on this slide are photos of some organizations that are specific to the Houston area. So these are often they're supported by faith communities, and often these programs include job training, language and skills classes, education support for adults and children, as well as community welcoming or community engagement activities. Unfortunately, asylum seekers in the USA are not afforded the same resources and support that refugees are. There has been increasing attention to the needs of asylum seekers at the US-Mexico border. The impact of policies still in place from previous presidential administrations is documented here by organizations like MSF, Doctors Without Borders, and the International Rescue Committee. These policies may create an environment that increases the exposure to disease and trauma for asylum seekers. The health needs and epidemiology of asylum seekers often follow the same patterns as those who are refugees. In all of these contexts, whether it is an Ivorian refugee in Liberia or an asylum seeker in the USA, we also must look at the health status of the host community. This recent report by the Kaiser Family Foundation does a really good job of summarizing the recent changes in immigration and asylum seeking procedures at the US-Mexico border, as well as characterizing the need for health resources for these populations, communities, and these regions. Here you can see that in all 4 of the states bordering Mexico, those who are living in the counties bordering the international border have worse reported health than those in non-border counties. If we address these disparities in the health of the populations, we also may address some of the health needs of refugees and asylum seekers. There are many local and international organizations trying to address the needs of asylum seekers. These include dozens of initiatives, organizations, and consortiums along the USA and Mexico border. Here I'd like to highlight 2 organizations or opportunities for involvement for those who are not along the border. The first is Physician for Human Rights conducts trainings and webinars regularly for physicians and other health professionals so that they can help conduct medical exams and screenings to put into applications for asylum seekers. The second is Heal Trafficking. Asylum seekers are particularly vulnerable to human and sexual trafficking, and having a local education program that promotes awareness, screening, and intervention can identify those who are being trafficked, as well as connect them with resources to escape. Thanks very much for your attention. If you have any questions, please feel free to reach out to me via email. Also listed here are organizations and a few of the review articles I referenced in this presentation. Thanks for your participation in this program, and best wishes.